Welcome everybody to our Hearing in Children Who Have Down Syndrome webinar with Patrick Sheehan. Just to let you know, we are recording today's webinar and we'll be uploading this to YouTube within a sort of few weeks of today's webinar. There will be plenty of time at the end of the webinar for questions. After the presentation, we ask you to type these in the Q&A facility. We will be sending you a link to a feedback form shortly after the webinar. We would urge you to fill this out, please, because it's really helpful to us in terms of developing existing webinars and developing new webinars. Now, Patrick, who is giving today's webinar, will introduce himself more fully in a minute. But I'd just like to say that the DSA has worked with Patrick over many years on DSA resources. Patrick's contributed DSA journal articles, and we've worked with Patrick on events and DSA training, and Patrick's very sort of generously helped us with DSA resources. Just to let you know that ENT resources are available in the health section of our website. So, Jill, if you'd like to share the presentation, I'll now pass on to Patrick.
Hi, good afternoon, and thank you, Stuart, for inviting me to do the webinar, and Gillian. I appreciate it. Welcome, everybody. I am Patrick Sheehan. I am an ear, nose, and throat surgeon, but particularly a pediatric ENT surgeon. Next slide, Gillian. Next slide, Gillian, if you can. I have worked as a consultant ear, nose, and throat surgeon in Manchester for 14 years, from the 2000 to 2014, and then I went to the Middle East and helped to open up a new children's hospital in Qatar for 8 years, and enjoyed my time. And I'm now back in Dublin, my hometown, where I grew up and went to medical school. And importantly, I am the father of a son who now is next week will be 26 years of age, Connor, who has Down syndrome. So a lot of what I will talk to you about will be, as a professional, I ran a clinic for children with Down syndrome in Manchester. I was well known in the UK. For that, I lectured to medical students and surgical trainees for ENT. So a lot of their training came from me. But I also talked to you as a parent. We went through, medical issues with Connor when he was young, and we spent some sleepless nights in hospital. Next slide, please. So this is Connor. He's a typical Irishman. He loves his pints. Now Saturdays have to be spent in the pub watching his favourite football team, Manchester United. He works in Tesco, and even recently has now a new job in Wicks. So a couple of days a week in Tesco and once a week in Wicks. A lot of what we do for our children is because we want to get them independent or semi-independent. And Connor is semi-independent. He goes to work on the bus himself. He gets the bus to the cinema. He has a monthly cinema pass and spends a good amount of time watching all the latest films. In fact, he's actually travelled independently between Manchester and Dublin, where we still have a home, and Connor has supported living in Manchester. So he often comes over to me independently between the two cities. Next slide. And this is Connor doing some wild stuff on holiday in South Africa. He was skydiving. That's him just landing from his skydive. He's done paragliding, and he's actually swam the length of 2 lengths of the pool underwater with scuba gear that I have. So he's a pretty active young man. Okay, so enough of me as a parent. Now, Gillian, the next slide. So I was going to talk to you about not just hearing, but really the kind of things that come through to my clinic. When parents come to see me and we get chatting as parents, I end up getting more and more referrals. So what are the issues that I see in the children in my clinics and as a pediatric ENT surgeon, both in Manchester, in the UK, and in fact also in the Middle East. We'll do this for about 10 minutes, but I really want to open the talk to questions and answer specific questions, and usually we find that covers a lot of what we want to chat about. So we'll look at from birth to 2 years, and then from 2 years to 10 years. And really after age of 10, children are pretty healthy and they do really well, and you rarely need to see a doctor. So there is light at the end of the tunnel. The first 2 years can be a little bit harrowing. Yeah, next slide, Gillian, please. So as an ear, nose and throat surgeon, the first few years I deal a lot with the recurrent ear infections, the glue ear. At the early years, up to 2 years, it tends to present with discharging ear or pain in the ear. But after the second year, it tends to be more the hearing loss and hearing issues. Both are the same condition called glue ear, but they present differently in the different age groups. And then a lot of my clinic is spent with children having disturbed sleep, the unsettled night sleep. Obviously, a little bit more significant is obstructive sleep apnea, where they stop breathing for a few seconds and then have to take a deep breath in. A lot of symptoms I deal with are due to reflux, or what we call silent reflux. And they can be the underlying cause of many of the upper respiratory tract, and in fact chest infections can be because of reflux in our children. They have a short esophagus. Their low tone in the early years tends to lead to reflux symptoms. And we'll just briefly touch on anesthesia if they do have to go for surgery. Having a chat with the anaesthetist and the surgeon about the neck, the airway being a little bit smaller, and then the more significant issues in some children, and in a small proportion, we deal with children who have airway problems. Next slide. So at birth, I think many of you will, about 50% of children with Down syndrome will have heart issues. Some of them may be just simple ASD, atrial septal defects that are monitored and require no surgery. A small proportion have ventricular septal defects, VSDs, and they do tend to end up having some cardiac surgery. And then there are the more significant cardiac anomalies, fellows of tetralogy. So at birth, some children have issues with their heart, about 50%. And obviously they're dealt with by the specialist cardiologists and the cardiothoracic teams. Hematology, some children will have anemia and can have anomalies of the blood system, and your pediatrician will refer you to a hematologist. Then there's the recurrent chest infections, the ones that bring you to the emergency department, where you'll see an ED physician, pediatric ENT physician, and may end up being admitted to the ward to the pediatricians, and may even see a respiratory pediatrician. Much of that can be related to reflux, and if that's significant, then a gastroenterologist. So in the first few months of life, you may end up having a close relationship with a pediatrician, and he or she will refer you then to a specialist cardiologist, hematologist, respiratory physician, and ENT. From an ENT point of view, as I said, most of the times in the first 2 years, I'm dealing with discharge from the ear, earaches, maybe concerns about hearing, significant hearing loss, or that the child has failed a hearing test and has been referred to me. Other issues that from an ENT point of view can be the snuffly nose, just struggling to breathe through the nose, and having an unsettled night's sleep because they're all bunged up in the nose and the throat area. Swallowing can be sometimes a bit of an issue, either swallowing too quickly and then coughing and having coughing spurts, or refluxing relatively easy, which can, if that's significant, can lead to night disturbances and obstructive sleep apnea. The sleep disturbances can be relatively minor, just snoring, moving around. You know, I know that lots of children with Down syndrome, you put them in one position, and 20 minutes later you'll find them in a completely different position in the bed, and that, you know, occurred with my own son. But usually they're refreshed in the morning, they're active, and they're fine. We do get a little bit concerned when they show signs of obstructive sleep apnea. That means where the breathing becomes a little shallower, then stops for a few seconds, and then there's a deep breath in, and the cycle starts again. If that's frequent through the night, we would take action about that, and certainly investigate. And if there's significant dropping of oxygen levels, we would act upon that. And then the chest infections, as I say, we work with pediatricians, and my respiratory colleagues often refer to me children with Down syndrome because of recurrent chest infections. We look at whether this is related to reflux causing the problem, or whether it's significant nasal secretions coming down and getting into the chest, actually. I don't generally deal with the thyroid issues. It's pediatricians, but I always ask in my clinic that the thyroid is checked, that we, you know, if we need to do any surgery, does a blood test need to be done? We can always do that when the child's under an anesthetic, the needle's in place, so taking a blood sample is not a problem. And usually in my clinic, if they go to the surgery, they will have their bloods done at the same time, unless it was, you know, within the last 2 or 3 months when they've had the bloods taken. We're always conscious of the neck, the atlantoaxial instability. Some surgeons, younger surgeons who don't deal with the children with Down syndrome a lot, you may just need to remind them that that is an issue that needs to be considered. And it's just, there's no special precautions. It's just being careful and doing, you know, in tonsil surgery and adenoid surgery, we do have to extend the neck a little bit in order to do the surgery. And we just need to be a little bit careful when we're doing that, that we're not doing it reflexively. And the other thing that just needs to be checked is eyesight, and there's some good resources. Maggie Woodhouse will give has some excellent advice on eyesight and monitoring the eyesight. In the older age group, so in the first 2 years, surgery is not usually necessary. We try and deal with things non-surgically. So it may be that we need to give antibiotics. And if the child's getting recurrent chest infections, sometimes during the winter months, you know, November through to February, just putting the child on a low-dose antibiotic just keeps them healthy and out of hospital rather than in and out of hospital. With the hearing, we tend to, in the younger group, treat them with hearing aids, a bone-anchored hearing aid, or an adhesive hearing aid. And I'll show you this one. It's AdHear, which is relatively new. It's probably on the market for about 8 years, but sometimes you may need to ask the audiology department, would they consider that. Cleaning the airways out with saline and or steroid sprays. But again, surgery generally in the first 2 years of life is not necessary unless the symptoms are significant. Then from 2 years onwards, next slide, Jillian, please. I'm rushing through this because I really want to kind of get through this and concentrate on the questions and answer session. So Gillian or Stuart, just keep me on track and let me know about, you know, when we've done 15 minutes. Management in the early years, saline douches. The Sterimar is my favorite. I should have shares in this company, because almost every child I see gets prescribed Sterimar. It's fantastic. It comes out in a very fine mist, and it just gets into all the nooks and crannies of the nose and clears the nose out. Consider dairy-free diet. A lot of our children are dairy intolerant, temporarily dairy intolerant, and I found that, you know, when parents try a dairy-free diet, and in my own son's case, we probably went through about 9 months of having a dairy-free diet, which made a big difference. We can then go on to antihistamines. I've mentioned the low-dose antibiotics for the winter months, and that can be something that you can talk to your GP or your pediatrician about. But a lot of pediatricians do often suggest that as a treatment, just to get the children over the winter months in the first 2 years. And nasal decongestants if necessary. Okay. 2 to 10 years, it's almost at 2 years of age, and on their birthday they just suddenly change, and all the kind of admissions to hospital become less and less, and at 2 years of age they really are non-acute problems that our children have. It tends to be ENT, actually, with, you know, failed hearing tests, reduced hearing, and the disturbed sleep maybe become a little bit more problematic, and it's those years that we then consider surgical options. So from an ENT point of view, I'm often discussing the grommets in children with Down syndrome, which are little tubes that we put into the ear. Technically challenging because our children have narrow ear canals, but can be done. And as I say, before 2 years of age, the surgery is probably not possible, but certainly after 2 years, it is possible. Removing the adenoids and tonsils, and that's probably where a lot of my dealing with children with Down syndrome is removing the adenoids and tonsils in our children. It works well. It's certainly, you know, the feedback from the parents, they tell me it dramatically changes issues. But I always warn parents, please be careful of weight. Don't allow our children to put on the weight. If, you know, the old days of having young adults with Down syndrome who were very overweight, they will always have problems with sleep apnea and breathing issues at night time. So keep our children active. You know, park the car at the other end of the car park when you're going shopping. Just that little bit of extra weight. Get them involved in play groups, swimming, sports, or whatever, and just try and keep the weight down. So you'll have less and less problems as they get older. Next, then from 10 years onwards, really, most of the time I just give my patients an open appointment. They come and see me if and when there's a problem, or, you know, we're monitoring a hearing on a once a year basis, but they're generally fitting well. And each and every time they come to see me, again, they're warned, just keep that weight under control. And if there's any specific issues, we can deal with them. Next slide. Some tips for you if you're going to a clinic. If you are concerned about your child's sleep and sleep apnea or disturbed sleep, it's a great idea because it's difficult to get sleep studies. You know, in England, you may see a ENT surgeon and you say, oh, I'll get sleep studies, and you'll wait ages for the sleep studies. But a simple video clip. So what I tell my parents is, short 40-second video clips, different nights, a good night, a bad night, a night you want to show me. Put them all into one folder. You know, really do put them into one folder on your phone. And then when you see the ENT surgeon, you're going to that folder and you're flicking through a few video clips. You know, seeing 3 or 4 video clips will immediately tell us the problem, and we'll tell you, yeah, you know, this is significant enough to warrant surgical intervention, or let's try simple things. So an hour or so into the child's sleep, go into the bedroom, turn a light on. Video clips is necessary, not just sound clips. Turn a light, either a main light or a bedside lamp, and just take 40-second video clips over different nights. NHS clinics can be busy. There's always a team there, but if you want to see the consultant, that is your right. You may have to wait a little longer to see the consultant, but do ask the nursing staff if you want to meet a consultant rather than one of the junior doctors. But usually the junior doctor will discuss the case with the consultant if there's any issues. Again, the NHS has a duty to make special allowances for children with special needs. And, you know, if your child is creating a little bit of a commotion outside and you think it's because he's tired or he's been waiting too long, have a word with the nursing staff. And usually in a children's hospital, they're understanding and will try and keep the peace and maybe get you in a little bit ahead of your the next appointment. Audiograms, next one of the slides I have here will, you know, you can download them from the web, a nice photographic audiogram, bring that to the clinic and show it to the audiologist, ask them to mark it up on the audiogram is helpful. Always ask the audiologist for a copy of the audiogram to give to you. As I said before, if your child's going to have surgery, ask if any bloods that can be taken under a general anesthetic could be done. It's not a problem. It takes us 3 or 4 minutes extra and it works out. When a child has grommets put in, you have a window of opportunity of about 6 months where there will be no glue ear and the hearing will be at its best. And that's when you really do need to work on speech and language exercises and working Makaton and hearing and really getting their speech improved. I do always say to parents, ask for a copy of the clinic letters that we write to your GP and with the outcome of the letter, but you're entitled to have a copy. A lot of pediatricians do it anyway, but sometimes surgical teams won't do it out of habit. But you can ask, can I have a copy? And it's a good idea to get a copy of those letters and keep a folder of medical issues because you know, sometimes you go to a clinic and they can't find a letter or something happens. Ask hospitals in pediatric hospitals about the hospital passport. It's a simple booklet that, you know, look, what's your child's favorite name? You know, what do they like to be called at? What's their favorite color? What's their favorite toy? And it's just a simple passport to make their hospital stay more pleasant. And the other important thing to do is write down any questions you want to ask the consultant or the medical team, because you'll go into a consultation and you'll forget and you'll come out and think, I wish I'd asked this or that. Write them down, bring them into you and refer to them during the consultation. You'll have the answers there and then. Okay, next. That's the audiogram I was talking about. You can download that off the internet. If you put the audiogram, go to images and you'll find one of these or one that suits you. Print it off and bring it to the audiology, and they will mark up your child's hearing levels on that. We call them thresholds, and you'll see straight away, you know, anything above the line they mark up, they cannot hear. So, you know, the top corner there, top right corner is a bird tweeting. Unless your hearing is perfect, you probably won't hear that. A watch, you know, again, is unless the hearing is perfect, they may not hear a watch ticking. But ask your name. Certainly, if it's below that yellow crescent, then we're not hearing speech and language verbs and constants, and that's where we would be acting and putting grommets in or hearing aids or whatever. Okay, next one, Stuart. How am I getting on? Am I okay?
We've just gone past the sort of 20-odd minute mark, Patrick.
Okay. This is a tympanogram. This is what measures whether there's fluid in the ear or not. If it's a little peak, that's normal. If it's flat, that's glue ear. In our children with Down syndrome, it's usually going to be flat. If it's the peak is to the left of the 0 mark there, it means that they have a propensity to glue ear, but no glue ear at the time. Next one, Stuart, and then I think I'll. These are some resources. There's a clinic for children with Down syndrome in Guy's and St. Thomas's, Birmingham. My colleagues in Birmingham have a clinic for children with Down syndrome, as do my colleagues in Liverpool Children's Hospital. And obviously myself, I now have a clinic in Dublin. Some really good websites. The National Deaf Children's Society have a great booklet on Down syndrome and childhood deafness. The Down syndrome medical interest group is primarily for doctors, but there's again some good resources there. And obviously the Down Syndrome Association have some great resources. And specific ENT type issues is ENT uk.org, and that's one of a very good website to go to. Put in the condition that you're looking for and you'll get some very good advice. I think I'll one last slide there, Stuart, and then so these are the different types of hearing aids. This is a conventional behind the ear hearing aid. This is a BAHA. The top right is a BAHA, and a newer one here is called the AdHear, AdHear. And it's a hearing aid that just sticks behind the ear, because a lot of our children have sensitivities to wearing hearing aids, or the earlobe is too floppy to wear a hearing aid. So AdHear have brought out this hearing aid. You may need to ask your audiology specifically, what can I have one of these, and why can't I have one of these maybe? Okay, I'm going to stop there because I think we'd like to get the questions and answers.
Thank you ever so much, Patrick, for that excellent presentation. I'll just take a look at the questions and I'll read them through for you. Okay, the first question is, do you have an opinion about grommets for a child with persistent, consistent, conducting hearing loss? I was told that persistent glue ear can result in permanent hearing loss.
So glue ear, there's two ways of treating them, and there's no right or wrong. In the younger age group, because surgery is so difficult, under 2 years of age, it would be most likely treated with hearing aids. So the glue ear persists, but the hearing aids amplify the sound, and we get over that. Surgery under 2 years of age is technically very difficult, and the canals are very narrow, and to try and get a grommet into the eardrum is technically very difficult. After 2 years, I can tell you this, it's still technically difficult compared to a typically developing child, but generally a consultant will get a set of grommets. The problem with grommets in children with Down syndrome is they don't last as long as a typically developing child. So with typically developing children, we'll say to you, they'll usually last for a year to 9 months to a year. And a child with Down syndrome, realistically, they'll probably last for 6 to 9 months. And they'll most likely need a second, if not a third set of grommets. So if they can get the grommets in, that's the way forward. And really, it's not curing the condition. It is only temporarily relieving the symptoms so that the hearing thresholds are improved and their speech and language development is improved. So, and our children with Down syndrome, they tend to start the problem at an earlier age and go through to an older age group. So they may start the glue ear problem at 6 months and go on to the age of about 7 or 8 years of age. But ultimately, they will grow out of the problem. It's those years between 6 months and 8 years that we're trying to improve the hearing levels and get their hearing thresholds at their maximum, so their speech and language development improves. I hope that answered the question.
Thank you. The next question, my now 15-year-old has been re-diagnosed with severe obstructive sleep apnea. They were originally diagnosed at 6, 7 years old, so they had their tonsils removed. She didn't have adenoids. ENT have advised CPAP. We were surprised she developed sleep apnea as a teen. Is this typical? She has a normal weight. She's an active teen, but has complex medical history, e.g. underactive thyroid, ASD and bowel issues, etc.
That to me sounds like a low tone issue, low tone. Yes, it is unusual to develop this at 15. It tends to be in the children that tend to be overweight. And if they've already had their adenoids and tonsils removed, then really the next, assuming weight is within normal BMI, then the next way to treat it is with a CPAP machine. Now, the CPAP machine takes a little bit of time. Don't expect to put a CPAP machine on the child. Even an adult sometimes needs CPAP. It takes a little bit of time to get used to, but slowly but surely, when they realize they're getting a better night's sleep and are waking up refreshed, they tend to adapt to them. It can take a few months, but slow progress will improve the situation. But your respiratory physician will be generally the person who will guide everybody on with CPAP machines. And if they feel that a relook at the adenoids or that can be done in clinic at 15, your son or daughter may allow the little camera to be passed down in clinic. It's a little tiny flexible camera that we can look at the adenoids and double check, or at worst case scenario is a short anesthetic. But your ENT, your respiratory physician will guide your respiratory pediatrician at 15 years of age.
Thank you, Patrick. The next question is from the parent of a 9-year-old who is under ENT. She's non-verbal. Parent says she babbles a lot, holds her hand out for communication. She's had regular hearing checks, some under sedation. She had her adenoids and tonsils out in 2019, and she had grommets put in both ears at the same time. They've fallen out, and she's back on a hearing aid, a Baha hearing aid. She struggles to wear a hearing aid as she has glasses too and sensory issues. Her hearing is always checked in a generic way, according to the parent, where she has to respond to noises playing at different levels. Our ENT told me that it's highly unlikely that she will speak now, which was quite upsetting. So it's how to really understand what her hearing levels are and to support her. Also, she gets letters for earwax removal, but she always ends up having ear infections after that, as it's hard for her to sit still. So how to help her now? Can you advise?
Okay, at 9 years of age, I would hope that she's under a children's hospital, a pediatric audiology team and a pediatric ENT team. That's what we do. Other ENT surgeons deal with head and neck cancers and major ear issues, but as pediatric ENT, we deal with children with special needs. So if they're not with a pediatric audiology department, I think ask for that referral to a pediatric audiology. If you're struggling, the Baha, I was the one who introduced Baha to children with Down syndrome. I have a few articles a few years back, and I think most departments now provide that as an alternative. But AdHear, and if you go to slide 16, actually slide 18, Gillian, AdHear brought out this hearing aid, which my colleagues now use in a lot in Birmingham. And as you can see, right bottom, the slide 18. Yeah, that's it there. It's a small hearing aid that has a little sticky tape on the side, and it just sticks behind the ear. So it works, but in the same way as a Baha, bone conduction, but you don't wear that horrible band, or you don't need the particular surgery for the Baha. And that really is now the thing about it is expensive, but if it is the only way of treating your son or daughter, it should be considered. And as I say, a pediatric audiology department will often say, right, if this is the only way to deal with it, so be it. That should be offered to you. It's called AdHear, and it's from the medical company Medel, Medel. ask your audiology department for consideration for that. What was the other part of the question, Stuart?
Okay.
Was there another part to that question?
Okay, I'm just checking. So you covered the Baha question. And I think you've covered the sort of the whole question, Patrick, because the mum was also asking how to sort of understand what the hearing levels of her sort of child are. She did also touch on sort of earwax removal and how that's sort of a little bit problematic. And
If
yeah.
If the child will let the ENT surgeon, wax doesn't cause any hearing loss. Wax is actually protective in the ear. It helps to protect the ear. In our children with Down syndrome, their ear canals are a little bit narrow, and so the wax can just accumulate a little bit more. The problem with wax is when you're wearing hearing aids. If the canal fills with wax and then you're wearing a hearing aid, a conventional hearing aid, not a Baha, the hearing aid will feed back. You'll get that whistling noise from the hearing aid, and that's because there's not enough space between the hearing aid and the and the space hitting the wax. So in those cases, if your child will allow the ENT surgeon to just gently microsuction with a suction device or even just an instrument remove the wax, great. Putting Waxall or one of the solvents in tends to expand the wax, and then you just get a child complaining that they can't hear because the wax is expanded. So removal by an ENT surgeon will probably be the best option, but don't try and use cotton buds or anything like that. And Waxall, I'm not convinced will make any big difference.
Thank you, Patrick. The next parent, you have really sort of covered this already, but she also asked about earwax and whether or not it is more common. She has a teenage daughter who has sort of quite a big build-up of earwax, and this has been sort of removed over sort of several appointments. So I think the question is that primarily, is it more common in people who have Down syndrome?
I don't think it's more common. It's just that it's more problematic because the ear canals are narrower, and so you don't have a lot of space for it to accumulate, and it just blocks off the ear canal. I probably in each of my clinics I'll have one child that it takes a little bit of coaxing, but we generally, it takes a little bit of time and we coax her, and I'll remove some of the wax. If it's a real problem and you're struggling to wear hearing aids and the hearing aid is the only option, I will often say, let's just put the child under a short anesthetic, clean the wax out, and you're in and out of hospital in 2 hours, and problem solved. So it is an option that's available if the child wears hearing aids and can't wear them because the wax is causing feedback.
Thank you. The next question is from the parent of a young man who's 17, who's had glue ear since birth. They ask, is it likely that the glue ear will ever resolve? Is there anything that can be done to clear it now? He had one set of grommets at age 7, and he's used hearing aids since then. He rarely gets ear infections these days.
So at 17, it's likely that it's not glue ear per se. It may be that it was long-term glue ear and the what we call adhesive otitis media, where the eardrum has developed adhesions and affected the mobility of the eardrum. So putting another set of grommets at 17 is unlikely going to make any difference. Obviously, it depends on the examination. And really going forward, you're probably better off with continuing with the hearing aids if they're comfortable wearing hearing aids. Behind the ear hearing aids are the best option. You have the bone anchored hearing aids, the Bahas. They're acceptable because children can't wear a conventional hearing aid, either feedback or every time they wear the conventional hearing aid, they get a discharging ear, maybe because they have a perforation or not. So we then go for a Baha. In the younger children, we use a Baha soft band, which is the band that goes around the head and the Bahas attached to it. But in an older age group, 10 words and upwards, we do the surgical procedure to put a little a fixture abutment, for a better term, a screw into the bone, and that the hearing aid attaches onto that screw and conducts sound through the bone of the bones of the skull to the hearing center, and has very good results. But the AdHear, again, I'd suggest maybe talking to your audiology about the AdHear and trialing it, even if they can offer it to you, has reduced the amount of Baha surgeries that ENT departments are doing now.
Thank you. The next question is from the parent of a teenager who's 14. The parent says that she suffers from persistent nasal discharge, often thick and green. She has had both tonsils and adenoids removed 4 years ago after sleep apnea was diagnosed. She suffers from glue ear from time to time. The last audiology appointment was borderline, but the best it's ever been. Hearing aids have been tried a few years ago, but don't seem to be necessary at the moment. She's dairy-free and gluten-free. She's very active, get lots of fresh air, and we live by the coast. She has a good fit weight. She has repaired Fallops tetralogy at 5 months old. Heart is monitored yearly, but now having more in-depth tests to assess heart function. No concern to date. We're currently awaiting an ENT referral. Do you have any tips to help clear the airwaves?
Okay, so with the gluten intolerance, it sounds as if she has a condition called atopy, ATOPY, where it's kind of the allergic rhinitis, the sinusitis, the conjunctivitis of the eyes, the dermatitis. It's the body's own immune system working against everything in the body and just causing all sorts of problems. But from an ENT point of view, from the blocked nose, I am a really great believer. First of all, she's how old? She's 14, did you say 15?
14,
So she should be able to really blow her nose. A lot of children do not know how to blow their nose adequately. Making sure that that technique is taught. It's like, as I say to parents, it's like riding a bicycle. They don't know how to do it. You're not born with that technique. You teach them that, and they can't do it, and then one day they're off. They can do it, and they great job. But if they can blow their nose adequately, that's great. The other measure is that Sterimar that I mentioned. You buy that in any decent chemist, at probably about £5. I've got to be careful here, talking euros. About £5, and it's just seawater, sterilized and put into a water, but it comes out in a very fine mist, and it's great for getting into the nose. And you can use it as often as you like or as little as you like, but certainly twice a day, and just clearing the nose. Use that for a month and see how you get on with it. Give the bottle to your son or daughter, and let them do the spray, because they can't do any harm and they won't overdose or anything like that. If after a month you feel that there's some improvement, but there's room for more improvement, then talking to your GP or your pediatrician, but GP, asking for a nasal steroid spray. Now, the important thing about a nasal steroid spray, and that's Nasonex, Flixenase, one of those, there's a variety of proprietary ones, but the important thing about a steroid spray is you must use it every day. You build up a therapeutic level and you maintain that. So if you miss a day, and it's not a problem, but if you miss 2 or 3 days, a weekend, you will drop the levels below therapeutic levels, and then it takes another 2 or 3 days to build them up again. So my advice usually is, make sure you use it every day. The last spray into the nose at nighttime, 2 puffs into each nostril at nighttime, and use it for 6 weeks. Stop for 2 weeks, and at the end of the 2 weeks, make a decision. Was it helpful being on it? If it was, then you go back on it and repeat that cycle. 6 weeks on or 8 weeks on, 2 weeks off, just checking whether the child really needs it. If you find after 2 weeks off that there's no difference on or off, then you can stop using it. It's not helping. But the nasal steroid sprays are safe. They're a very low dose and they only work inside the nose. We're not worried about any systemic steroid toxicity or anything like that. It just works inside the nose. Hopefully that will give you some trial before you go to see the ENT person.
The next question is from the parent of an 8-year-old who still gets glue air. The parent says it had been better, but it's appearing again this year. The parent has 2 questions for you, Patrick. The first is, on the first night of a heavy cold, she does wake and is alarmed by struggling to breathe. She can breathe, but suddenly sucks in sharply and loudly. We sit her up and encourage coughing and nose blowing till it passes. This isn't obstructive sleep apnea, is it? And the second question is, hearing tests are often limited by the presence of wax. So audiologists recommend monthly use of olive oil to reduce the buildup. I use a measured spray to control it. This is so they can use in-ear buds instead of headphones, which compress her ear a bit so don't get a good test. Is there anything you recommend?
Just bear with me. I'm just going to get someone, the Hoover's coming closer to me. 1 second.
No problem.
Sorry.
Sorry about this, everyone. I think this is one of those unavoidable incidents. Bear with us for a minute.
Sorry about that. Problems of working from home. Sorry, say
do you want me to read through the sort of question?
So,
yeah.
So that question to me sounds like that needs to be investigated. The breathing issue does potentially sound like obstructive sleep apnea. I think that needs to be investigated. So if you haven't seen ENT or are waiting someone, certainly have the video clips that I suggested at night time of those apneic episodes positioned in the bed. It's vitally important that it's video clips. So light on, either bedside lamp or main light. 40, 50 seconds, minutes, different nights, a good night, a bad night, a night that this is what I want to show you. Put them all into one folder so that you're not searching the phones. Parents come in to me, I have some videos and we spend 10 minutes looking for the video on the phone, which can be problematic because I don't have that time. But if it's all in one folder and we're just flipping through different videos, that'll almost certainly you can give the diagnosis. And that may tell us whether we need to go for sleep studies and how quickly we should go for sleep studies. And at 8 or 9 years of age, if they've had their adenoids out before, we may need to be looking at CPAP as an option. And that would be a joint consultation probably between ENT and respiratory pediatricians. I hope that answered the question.
Thank you, Patrick. There was a second part, just really around hearing tests and earwax. Audiologist suggests that the parent uses some olive oil to sort of to reduce the buildup. And the parent's just asking, is there anything else you'd recommend to help get a better hearing test?
So wax doesn't cause a significant hearing loss. It really is. If that audiogram I showed you would cast less than 5 decibels, and we're looking at 10, 20, 30 decibels. So wax, unless there's a significant buildup, and the only time I've really seen that is when I did clinics in India where children hadn't seen ENT and there was a huge amount of wax in both ears, and we spent a lot of time just de-waxing the ears. But olive oil, as I said earlier, it tends to soften the wax, expand the wax, and then you've then got a soft wax in there. But the worst thing you can do is use cotton buds. All one will do with a cotton bud is push wax deeper into the ear canal and up against the eardrum, and that can be painful and problematic. So whatever you do, don't use any cotton buds. If you can see a bit of wax at the entrance of the ear canal, just with your little finger, try and roll it out. Or I know some of the high street audiology clinics do offer a de-waxing, and that usually is with a suction device rather than syringing or any. Again, syringing in children with or even adults with Down syndrome is not going to work because the ear canals are too narrow. So ideally, if you can get to your ENT department, and they will, if your son or daughter will allow them to just gently microsuction or use a little instrument just to pull the wax out, it may work.
Thank you, Patrick. The next question is from a parent who asks, how long can glue ear take to clear?
So, as I said earlier, in children with Down syndrome, it starts at an earlier age. I would say it potentially starts at the age of 6 months, but can go through to an older age group, 7 or 8. So in typically developing children, we would probably see them at starting at 1 year and going through to 5 or 6 years of age. But ultimately, the cause of glue ear is the eustachian tube, the tube that you and I as adults appreciate when we're in an aeroplane, and we have to equalize our ears in an airplane. That's the eustachian tube that equalizes pressure. In children with Down syndrome, that tube is narrower because the whole midface, the back of the nose, the mouth, and where the tonsils are is all a smaller space. And the tube itself is smaller because of the hypotonia in the younger age group. It's not working as well. So as a result, you get a negative pressure in the ear, and that negative pressure draws fluid into the ear, and that fluid is a thick. It's called glue ear because it looks exactly like the glue that we used to use in our school days, pasting pieces of paper to copybooks. So it's that golden thick fluid, and it just surrounds the bones in the middle ear and prevents them from vibrating adequately and conducting the hearing loss. That's why it's called the conductive hearing loss. So it does start at an earlier age, but usually improves by the age of 7 or 8 years of age. If it goes beyond that, then ENT need to see you, and there may be other reasons why the hearing loss is persisting, either a perforation of the eardrum, or that there's adhesions or bands within the middle ear. And remember that 20% of our children with Down syndrome have what we call a sensory neural hearing loss. So that's similar to the hearing loss that we all get when we're older, in our 70s. It's damage to the nerve, to the organ of hearing, the cochlea, or the nerve that's taking the signals from the cochlea to the brain, called a sensory neural hearing loss. And for that, there's no surgical intervention. For that, we need conventional hearing aids, or in some cases, a BAHA may help.
Thank you. I'm aware that sort of time is ticking, so we only have about 7 minutes. So we're probably only going to be able to get through a few more of your questions. We'll do our best. The next one, Patrick, I'm not sure whether it's one for you, but I will read it out. It's the parent of a 10-year-old who says that he has rhythmic motion disorder during sleep, and he used to rock and bang his head during sleep. Is that one that maybe the parent should give us a call about, do you think? Or
So disordered sleep patterns can be anything from ENT to a neurological. I think in that case, I would say take the video clips, show them to your GP, or hopefully your child's under the care of a pediatrician, and your pediatrician will automatically know who to send refer the child to, neurology, ENT. But yes, you show those video clips to your pediatrician, I would say.
Thank you. The next question from a parent who said that her daughter lost her hearing in one ear age 7. No reason was found for this. She's now losing higher tones in her good ear. She's now 15 years old. She says her daughter was born at 32 weeks. Could this be a factor? And is the hearing loss likely to be progressive?
So one can't say. Obviously, she'll be under the care of audiology, and they will monitor her hearing. I hope at least once a year, but maybe even more frequently, 6 monthly. If there is a progression of the hearing loss, then she will need to be investigated by ENT, and that will include a lot of blood tests, because you may have a virus infection. Cyclomegalovirus is a common one. It's a virus infection that can be had during pregnancy or a young age group, and it just presents with a mild cold or flu, but can affect the hearing. So that type of progressive hearing loss, particularly if it's in her only good ear, needs to be monitored very closely. And audiology I would hope that they would be seeing her on a yearly, if not 6 monthly basis. And if it's progressing, then fully investigate. And that may include MR scans, magnetic resonance MRI scans, or CT scans, and chatting with the ENT department, but certainly absolutely monitoring of that situation.
Thank you. I think we've got time for probably one more. So this parent says, my son is 5. He has obstructive apnea with a few isolated incidents of central and glue ear. Local ENT tells the parent that grommets won't work because they fall out. They've also been back and forth about T and A, because they tell me it may not make a difference. We would like to try, but they're reluctant. Would appreciate your advice, please.
Okay, well, I can tell you grommets do work. I'm honest with parents. They last for a shorter period than a typically developing child, but usually they'll last for 6 to 9 months, and they may need to be repeated. So the child may need to have a second. Usually, will probably need to have a second set of grommets, or even a third set of grommets. And if they're working and they're falling out, consider putting a slightly different type of grommet in. But I wouldn't deny the child the grommets just because they have a shorter acting. And in children with Down syndrome, all the evidence does show that adenotonsillectomy, removing the adenoids and the tonsils, or shaving even the tonsils, improves. Again, the reason was, I alluded to earlier, the space at the back of the mouth and the oropharynx, the area where the tonsils are, is smaller in children with Down syndrome. And so therefore, even normal sized tonsils are taking up a little bit more space than they should do. The whole area is just crowded. And by removing the tonsils and the adenoids, you significantly improve the airway. I have great experience of removing tonsils and adenoids and making a dramatic improvement. But I again caution, don't let your child put on weight, because if they do, the sleep apnea will come back again, and then there is no further surgery that can be done, and you're then looking at CPAP if the obstructive sleep apnea is significant. But certainly, so that person, if they're not under the care of a pediatric ENT team, I'd ask to see a pediatric ENT team.
Thank you. I think we can probably just slip in one more, and it's the parent of an adult. He has in-ear aids, but he gets so much wax, they get blocked and stop working. He then won't wear them until he eventually gets the wax sucked out, which doesn't happen as scheduled. The parent's question is, would he be suitable for an abutment Baha?
So the in-ear ones obviously fit a little bit closer into the eardrum, and the reason why he finds them difficult is because he's getting wax in front of the hearing aid within the canal, and that's causing a feedback. So he's got probably getting the whistling. If he will tolerate the microsuction, so going into an ENT clinic and sitting down and having the ENT surgeon using the microscope and the suction device, and explaining to them that this is, his life wearing hearing aids, they should make a routine 6-monthly appointment for him to have his wax removed. That's a treatment, and you shouldn't be denying it that. So every 6 months coming in and having it's easier to do every 6 months and removing a little bit of wax than, you know, leaving it 2 or 3 years and then spending a whole lot of time trying to remove a lot more wax out of the ear. Olive oil, I think, will just expand it. If it's a problem, then you could discuss a BAHA with audiology departments. Nowadays, they should be able to even trial him with, you know, wearing a BAHA or an AdHear for a couple of weeks and say, you know, as an adult, you'll be able to say, I like it or I don't like it. And then that conversation can go ahead with the AdHear. But I would have thought talking to the ENT department and saying, look, you know, he gets great benefit from his hearing aid. It's just the problem of the wax accumulating. Can we have a regular 6-monthly appointment?
Thank you very much, Patrick. I'm sorry, everyone, but we have now reached 3 o'clock, so we won't be able to answer any more questions. There's obviously been great interest, which is brilliant, you know, judging by the number of questions. So we'd like to say thank you ever so much, Patrick. That's been amazing, and we're incredibly grateful. And just to say that to all of you who are attending, that we will be sending an email to you with a link to a feedback form, and we would ask that you fill that out for us because it's incredibly useful in terms of developing existing and future webinars. And thank you all very much for attending. Jill, is there anything that you would like to say?
I have nothing further. Thank you, everybody, for joining, and thank you, Patrick.
Thanks very much. Appreciate it.